Good morning. We are all familiar with a patient who comes with gangrene of the toes, breast pain, no Doppler signal in the foot, and no target artery in angiography. Those patients are considered to be non-reconstructible. Therefore, they are candidates for leg amputation. 20 years ago, we tried to solve the problem by using the venous system, which is not affected by atherosclerosis. So we performed an operation similar to the in situ bypass, using the saphenous vein as an inflow with anastomosis to the superficial femoral artery, ligated all tributaries up to the ankle level, and then we exposed the distal saphenous vein at the ankle, transverse venotomy, destruction of all valves of the saphena with lametta valvulotome, and closing the venotomy and the skin over. Immediately after the operation, we felt good pulsation over the dorsal pedal veins, and the temperature started raising. The following day, we found that the foot had excessive edema, which was not treated by elevation, and that didn't change the situation. The following day, the edema increased even more. A week later, we found that there was dorsal foot skin necrosis, and the following week, infection of the operating site, and after a few weeks, we had to perform amputation. We performed 4 such kind of operation. The second had the same result, and at the 4th operation, we tried to improve the technique by destroying the dorsal vein valves, but it didn't change the outcome. After the 4th operation, we stopped performing the operation, and then 3 years ago, a patient was entered my ward, and with, again, gangrene of the toe, rest pain, with no target arteries. 6 months before, we performed a below-knee amputation on the right leg. So now we had a problem, and I decided to consult with Mario. Mario the plumber. Mario the plumber, I asked him, could you explain to me why our patient failed, why the operation failed? He said, that's very easy. Why? Because what happens if your home water pipe system that can stand the 4 atmosphere of pressure, if I introduce a 40 atmosphere of pressure, what would happen to the system? So I said, obviously, it will burst. So what we do, we are doing exactly the same thing. We are connecting the saphenous vein to the high pressure of the arterial system and closing all the saphenous vein tributaries. So we're causing elevation of high pressure, systemic pressure, to the venous system, which operates on 14 to 16 millimeters of mercury. So introducing 10 times more pressure in the foot. So as a result, there is leakage of blood through the venous capillaries, edema, and all those consequences of the foot edema and necrosis. So I asked him, what can I do? How could I solve the problem? So then I understood, this is, by the way, David, the human plumber. So I said that we have to design an operation that the aim of the operation is to reduce the distal pressure by ligating the proximal tributaries and leaving the distal tributaries open as decompression valves to reduce the distal venous pressure. This is the patient with ganglion of the toe, no distal target artery, and on MIBI uptake, there is no oxygen uptake to the foot muscles. Here we present the first time a case of ISRA, which is in situ reverse arterialization, using the saphenous vein anastomosis to the superficial femoral artery, exposure of the distal saphena at the ankle level, and 8 centimeters towards the dorsum of the foot. Destruction of the saphenous vein valves with lametta valvulotome, and distally with irrigating cannula that was advanced with high pressure, hyperextend up to the toe level. This is the on-table angiography. In the middle you can see the saphenous vein, which has an inflow of arterial blood and return through the posterior tibial and anterior tibial vein. After the surgery, there was increasing temperature of the foot, good persection over the dorsum of the foot veins, and no sign of edema of the foot. 3 weeks later, we can see again the technetium update of the oxygen. All the muscles in the foot had good oxygen uptake. Now, this is the essence of the operation, and the first time we present the understanding of the physiology of venous arterialization, which was never presented before. Here we can see on the red chart, we can see TCPO2, transcutaneous PO2, that was measured at the dorsum of the foot, and on the green one is the flow measurement. As the flow measurement decreases, the TCPO2 increases. Why? On the left side, we can see the Doppler immediately after the operation. We can see a typical AV fistula pattern. A year and a half later, we can see a biphasic waveform, which means that there is increase in peripheral resistance because of edema of the because of the edema of the intima. Therefore, what happens is, as the peripheral resistance increases, the green flow measurement decreases. As the flow decreases, it enables enough time for oxygen to be diffused out of the hemoglobin cell to the venous capillaries and to the cell. And it takes, as you see, 6 weeks for the cell to adapt to venous oxygen consumption to a level that is curable, which is 30 millimeters of mercury. The leg can't survive below 20 millimeters of mercury. Now, and we can see that gradually the TCPO2 increases after 1,000 days to a level of 76 millimeters of mercury. We started at 3 millimeters of mercury, TCPO2, and now, the last 3 weeks, after 1,000 days, he has 76 millimeters of mercury. On the left, you can see, and you can see the transmetatarsal amputation, which healed under secondary closure. We took biopsy and sent to electron microscopy. On the left, we see this integration of all sarcomeres, and on the right side, 6 weeks later, we can see a normal appearance with parallel level of the sarcomeres and full cell division. In conclusion, venous arterialization of selective non-reconstructive link by in situ reverse arterialization, what we call ISRA operation, with proximal tributaries ligation, leaving the distal tributaries open for distal venous pressure reduction, leads to elevation of TCPO2 and wound healing. Thank you.